Good morning, friends. This is a detailed video about Generation X, Gen X IAOS EBOO system for performance enhancement. EBOO is extracorporeal blood oxygen ozonization system, and this one has very simplified tubings. This also happens to be the lesson 31 of advanced molecular therapeutics course and will be very useful for the participants of the course. As per the latest IAOS studies, for performance enhancement, post chemo cancer, rehab, viral infections, etc., 1 microgram of ozone per ml of blood existing in patient's body is the ideal dose. Thus, it will vary with the patient's height, weight, and the approximate blood volume. In this video, there are no patients, they are subjects, and all three subjects are medical scientists and doctors. I will show you the complete procedure in detailed videos without any speed and without any editing. All three wanted to experience Gen X EBOO personally before trying it on their patients. I would now like to give special thanks to Dr. Tanvi, endocrinologist from Mumbai, Dr. Pankaj Kathole, orthopedic surgeon from Nagpur, and Dr. Zahir Hamza, anesthetist from Kerala. The step-by-step procedure for all three doctors is documented here. In case you are interested in the procedure, please message me and I will teach you the details. This is the first step. A 500 ml of normal saline bottle is taken and hung on a saline stand. We now take heparin 4 ml of 5000 units per ml, making it 20,000 units per ml. This is injected into the saline bottle. All this 20,000 units will not be given to the patient. The heparin is shaken. The needle used for the same is kept on the saline bottle as it will act as an air vent. The remaining 1 ml of heparin in the bottle, which is 5000 international units, is now mixed with distilled water and the same is retained in a syringe which will act as a priming syringe. The donor set is now open. The new IAOS Gen X tubings are extremely simple. they just have three connections. One connection goes into the heparin bottle, heparinized saline bottle. One connection goes into the ozone bottle, and the last connection goes into the subject's Benflon cannula. Before we start the procedure, we attach the tubing to the heparinized solution, open and allow the heparinized saline to flood the tubings so that the entire tubing is primed and a very small amount of heparin remains in the lumen of the tube. This is a very important step. The EBOO flask is now opened. This has a stainless steel diffuser. The diffuser is attached to the top of the flask, and there are three spots. One is a small circle, one is a large circle, and one is a plus mark. The spike of the donor set is pushed into the large circle. Two 16 gauge needles are pushed. One is pushed into the plus mark, which will take the ozone tube, and the other is pushed into the small circle into which the waste port shall be attached. Once we push the needle into the ozone tube in the ozone stainless steel diffuser, we move the needle and make sure that the stainless steel diffuser inside also moves and shakes. This way we are certain that the ozone will go to the bottom of the bottle which contains the blood. The other end of the tube is attached to the ozone machine, which is not switched on yet. The waste port connection is now given, and the other end of that tube is now placed in the mouth of a glass bottle. The system is hung in a UVB holder. We will now open the recipient set and attach it to the bottom of the bottle. In the older videos, you would have seen that we waited till half the bottle was filled with blood, which was ozonized and tomato red, before attaching the recipient set to the bottom part. With practice, we found out that the most efficient method is to keep all tubings ready before the vein is punctured, and the recipient set, after being pushed into the bottle, is clamped shut and its opposite end is attached to the air vent of the heparin. We now reduce the speed of the heparin pump, of the perfusion pump, to below 10 drops per minute. We check the direction of the rotation of the machine, moving clockwise and anti-clockwise. we have to make sure the rotation of the machine is in the direction pumping blood from the vein into the bottle. The silicone section between the two red tapes. In this, the two red tapes are missing because it was one of the earlier tubing we made, but in subsequent videos you will see the two red tubings. So the section between the two red tubings is put into the pump. Dr. Tanvi is on the table with a big smile on her face, and we must use at least an 18G Venflon for the donor site. For a faster and a quicker procedure, it is advisable to use a 16G Venflon. You must choose a straight non-tortuous vein, and the Venflon is inserted. It goes in a single shot. The donor tube is now attached to this Venflon. Perfusion pump is set at 10. Heparin is started very slowly, and the pump is started. The instant the pump is switched on, blood will start being pulled out of the vein and will rise up to the bottle. This is a real-time video. The pump takes some time for the blood to start coming, and there we can see the blood rising up the tube, going right up to the perfusion pump. You can see the blood is venous blood, which is dark in color. Very low quantities of heparin are mixed with it. The blood rises against the gravity and slowly goes up to the bottle. Once we see the flow of blood is free, we can increase the machine speed to close to 40 ml per minute, which is well tolerated by a 16G Venflon. We can see that the heparin flow is barely minimum, and the heparin which was used to prime the sets has collected into the lower 1/3 of the bottle. Once the tube is immersed in the liquid, we set the machine. We can keep the regulator at 1/8 or 1/16 depending on the speed and the concentration desired. In Dr. Tanvi's case, I intend to give about 500,000 micrograms of ozone over a 50-minute period. We can see the blood gushing in and changing color. The recipient vein can be a smaller vein. As she has got a 16G donor site, we are putting an 18G on the recipient site. It is flushed with the pre-filled syringe which was made at the start of the treatment. We wait till the bottle is half full to switch on the ultraviolet light, and now we prime the recipient set press the bulb a few times to allow the blood to flow, and then we remove the air once the blood reaches the tip of the tube. This is attached to the recipient site. One by eighth of a liter in the new IAOS machine gives 90 to 100 micrograms per ml of ozone. 1 by eighth of a liter would mean 1 liter of oxygen ozone mix in 8 minutes. We can see the difference in color between the blood that is going in, which is dark violet, and the blood that is coming out, which is tomato red. The color difference is strikingly different, and we can see this difference in both donor and recipient sites of the patient. We have to monitor and ensure that the inflow and outgo speeds remain identical. We can increase the speed, we can decrease the speed of the pressure pump, thereby increasing or decreasing the blood flow. Similarly, if the bottle is filling beyond the half level, we can increase the recipient site. Once 42 minutes have passed and 500,000 micrograms of ozone have been administered, the tourniquet is released and the donor set is detached from the patient venflon. We can increase the speed of the perfusion pump so that the remaining blood gets into the bottle very fast. We can see that the blood is getting emptied into the bottle. All the while, during this 50-minute procedure, the level of the blood in the flask has constantly remained at 50%. We now remove the tubings from the perfusion pump, remove the heparin bottle, and also remove the spike from the EBOO flask so that the set can be discarded. The waste port and ozone port, however, continue till all blood is transfused. The amount of froth, foam and waste that comes out is entirely dependent on the lifestyle of the patient and the comorbidities. This is a normal person with no comorbidities who has got a very regulated lifestyle. She eats only organic food and limited food. She has got an excellent BMR, and so we can see that the waste part is practically empty. So, Tanvi is indeed a healthy girl with near zero waste. Now, we can switch off the ozone part and allow the remaining ozonized blood to fully drain into her. Once the bottle is empty, we will detach this set and hold it high and allow the entire blood to drain in her body. As you have seen, no ozone destroyer was used. A very high concentration of ozone was used. Still, nobody is wearing an ozone protective mask because the entire amount of ozone that was bubbled through the bottle has been taken up by the blood. As this is the only available borosilicate bottle, flint free, and the tubings are 100% silicone, plastic free, the absorption of ozone here is considerably higher. Once the blood goes back into the recipient site, the tubings are removed, you can see the bottle and the foam in the bottle. There is practically not much of waste generated during this procedure. The entire blood has been ozonized and a large dose has been administered to her. Now we start with the next subject. The next subject is Dr. Zahir Hamza from Kerala. He is an anesthesiologist and is seated on the couch. We always ask our subjects to wear an OT dress and remove the street clothes, one for the purpose of safety and sterility, and again it's a blood procedure where blood is pumped under pressure, and we have had cases in the past because of accidental leaks, the dress has become stained and it creates a bad impression. First of all, we take 4 ml of heparin, that is 20,000 international units, and the same is now mixed with 500 ml of saline. The needle used in the syringe is left behind as an air vent for the heparin bottle. The remaining 1 ml of heparin in the bottle, in the vial, is mixed with 5 ml of distilled water and kept ready as a priming syringe, which shall be used on the recipient side subsequently. So, at the cost of repetition, the first step is to get the saline bottle heparinized and ready, and the second step is to get the syringe with water and heparin to be kept aside for priming. All this must be done before all this is done, we must ensure that the patient has got good veins and we will be able to insert the cannulae of our choice in the donor and recipient site. The tubings are removed, they are simple, uncomplicated Gen X tubings. They have got only 3 connections. One is connected to the heparin solution. This heparin solution itself is attached to a 3-way, and the other end of the 3-way goes into the patient's vein, so that blood and heparin are sucked in together in a single flow. The other end has a spike that goes into the ozone bottle. The apparent flow is now opened and we allow both the tubes to be primed. Once the tubes are primed, we are ready to attach the ozone bottle. The IAOS ozone flask has silicone stoppers on top and bottom and a stainless steel diffuser, which is a pipe, and that is attached to the silicone part in the top. We now push the donor set into the large circle. Into the plus area, we will push the needle which goes into the ozone tube. We can move the needle and see that the tube moves to ensure that it is in the diffuser tube, and the third needle is pushed into the small hole which is for the waste out. The silicone tube attachment for the ozone tube is done, and that is attached to the ozone machine, ozone output. Another silicone tube is attached to the waste part, which is positioned into a bottle at the bottom. The connections are simplicity in itself. There is no question of air entering the patient's body. There are no renal filters. The entire tubing is silicone. The flask is borosilicate flint free glass with silicone stoppers in the top and bottom, with a stainless steel 316L diffuser without any membranes. This is a direct diffusion of ozone into the blood, so no ozone destroyer is needed. The entire blood, the entire ozone that is bubbled through the blood gets absorbed by the blood. The recipient set is now opened. This is attached to the big circle on the bottom of the bottle. And kept ready, we will start the outflow only when the bottle is half full. Once we check the ultraviolet and check everything is ready, we are now okay to connect to the donor site. A standard velcro elastic tourniquet is now used, and applied to the upper arm. The part between the two red stickers has to go into the perfusion pump, and this will avoid all confusions that people had with the previous versions of our EBOO system. I repeat again that the tubing has got two red colored sections, and the area between the two sections has to go into the perfusion pump. the perfusion pump is checked, the blood is flowing up through the machine, blood is rising up, we can see that the blood is coming at a good speed. Once the tube is immersed, we can switch on the ozone and we can see the bubbling of ozone in the tube, the appropriate regulator volume and the appropriate switch will determine the concentration of ozone which is coming into the bottle. Again, he is a healthy subject, there is not much of foaming, the blood is gradually turning into blood red or tomato red compared to the venous part which was little dark. Once the blood reaches the 50% mark, we can switch on the heparin, it's ultraviolet lights, so that the UVBI irradiation can be done. Now is the time to get a recipient vein which can be well and easily located in the wrist area. Here an 18G Venflon is more than sufficient. By the time the flask is half full, we should be able to insert an 18 or even 20G cannula for the recipient site. The sizes of cannulae decide the speed of inflow and outflow. So, if you have wider lumen cannula, both the donor and recipient sites will work fast and in a shorter time larger volumes of blood can be ozonated and higher doses of ozone can be given. Before the start of the procedure, we decide the quantity of ozone that has to be administered. Based on Dr. Zahir Hamza's general psych, he is a high performance young man, muscular, well built. So, I have decided to give him 600,000 micrograms for his performance enhancement dose. 600,000 micrograms. We can prime the recipient set. You can see the striking difference in colors between the donor and the recipient site, and whatever small amount of froth is coming out of the waste exit port which goes into the bottle. Unlike Dr. Tanvi, who had no waste, Dr. Hamza has some waste. I found that people who are pure vegetarians and avoid outside food do not have much of contaminants in their blood. So, these are 5-6 tubings. I will explain the tubings. You can see the color difference. The outflow blood is bright, the inflow blood is like Venus. That is the ozone tube, and the last one is for the waste. We have to match the inflow and outflow precisely and perfectly to ensure that the bottle stays, the level of blood in the bottle stays at mid bottle, meaning 55%. The pump speed can be increased or decreased, the outflow speed can be increased or decreased with the single aim of maintaining 50% of blood in the bottle. The calculation has been explained. 50% of the blood always stays in the bottle, the inflow and outflow are matched, and the excess foam, which is very less, a little part of it has been going through the waste tube. No, I think no, even in Hamza's case there has been absolutely no waste. The waste port is empty. Like Dr. Tanvi, Dr. Hamza also did not have any waste in his port. I am explaining to him the procedure and process. His procedure has taken about 30 minutes, 32 minutes. So 4 liters of 4 to 5 liters of ozone at 100 microgram per ml have been infused. 5 liters, yes, the 500,000 micrograms have been diffused in his blood. His pump rate was 38, 40, 45, depending on the blood that was going back. And though we have done an interrupted recording, it is rather a long video that is showing the steps. Once the desired time has elapsed and we are sure that the amount of ozone that we have intended to administer to the patient, to the subject, has been administered, the time comes to detach the donor site, increase the speed of the perfusion pump, empty all the donor blood into the EBOO flask, and return the blood to the patient. So the pump is switched off, the tourniquet is removed, the stopper is ready, the vein is collapsed, the donor site Venflon connection of the EBOO set is removed. The set is held by the operator while we increase the speed of the pump so that the blood in the tube is drained and the last of it goes into the flask. Because it is a closed segmented system, all blood enters from the top, all ozone enters from the bottom. Though it enters from the top slot, it goes through a stainless steel tube and bubbles from the bottom, and the outflow is from the bottom like a conventional drip set. So there is no question of air entry as it happens with renal dialysis filter systems. We finish once the entire blood is emptied, the pump is switched off, parts are removed and the tubings disconnected. The heparin bottle is almost more than half is still left, showing that not much quantity of heparin has been utilized. The primed syringe too has most of it left. The spike is removed and this is discarded. Ozone continues to bubble. There is no waste. The waste tube is into the room. it is into the bottle and there is no ozone destroyer in the waste tube, and still the mere fact that there is no ozone smell or discomfort to either the patient or myself or my nurses clearly tells you that the entire amount of ozone that has been administered has been taken up by the blood. So, roughly the blood can take 100 micrograms per ml for MAHT or EBOO, and we aim for a final blood volume dosage currently at 1 microgram per ml, meaning if a patient has 5 liters of blood in his body, we want 500,000 micrograms of ozone in his blood. If the patient is 6-footer having 6 liters of blood, we would aim to put 600,000 micrograms in his body. And for a young female, short, with about 4.5 liters of blood in a body, our aim would be to put 400 to 450,000 micrograms for an EBOO session. These doses are important for post malignancy, post chemo, renal dialysis, diabetic peripheral neuropathy, non-healing ulcers, chronic infections, not responding to antibiotics, viral infections. The response is dramatic. Of late, I have started getting sports persons for performance enhancement, and also movie stars, models, and other non-diseased, healthy subjects who are word of mouth recommendations, who want once in 6 months EBOO sessions to keep them ahead of the society in whatever they are doing, because this seems to enhance performance at all levels. Once gravity has stopped pumping in the blood, the cannulae are closed. I am now showing the removal of the cannula and wadding and bandages, because this is a very important step. First, moisten the adhesive bandage with sanitizer so that in a hairy patient you don't cause pain when you are yanking it off. A tightly packed wad of gauze is kept over the venipuncture site when the venflon is pulled out to ensure that there are no leaks. Pressure is applied and a pressure bandage is tied. This is because we have used heparin, and leaky wounds from heparin solution administered pricks can cause bleeding, which will cause panic to the patient. I am showing the flask to the doctor and explaining to him that the entire administered ozone has been assimilated by his blood. He has been smiling, and you see that we have not used any paraphernalia like an intensive care setup or monitors or pulse oximeters, because we have, after our trials and experience in large number of cases, realized that EBOO is one of the very safest procedures, provided it is done the correct way, with the correct instrumentation and with the correct ozone compatible tubings and flask. So, these lessons need to be watched repeatedly if you intend to do a precise and perfect job with repeatable and reproducible results. The next subject again for performance enhancement is an orthopedic surgeon, Dr. Pankaj Katole. I am speeding up this video because I don't want the procedure to be repetitive. At the same time, I want it to be educative and evocative. I have made a syringe. This was the older times when I used to keep two primed syringes and then add one syringe with heparin into a saline bottle. As the process is constantly evolving, we have improved and we have changed the methods. There may be minor discrepancies between the individual procedures, but the systems remain the same. This was the system, this was set before we put the red markings for the understanding of the people. It still has only two ends, one to the patient, one to the bottle. Both are primed. The central area which has to go into the perfusion pump has not been marked. We have to ensure that the whole tubing is full of the heparinized saline. A bottle is now opened. The top portion has three markings plus big circle, small circle. The blood in is put through a big hole. A needle is put through the small hole for waste. Another needle is put through the plus mark, and we can shake the needle to ensure that it is inside the diffuser so that the ozone goes right into the diffuser. Now we connect the appropriate tubings to these needles. Once we found that we had difficulty in connecting the needles, we normally switched on to connect the needles first and then push it into the bottle. The needles have been connected and bottle is primed. It is put into the holder. The height is adjusted and the silicone part is put into the perfusion pump. We have to adjust the direction and speed to ensure that the blood is sucked from the patient and goes into the bottle. He is a young person, but still we will start at a slow speed and slowly increase the speed. Here, as was one of the earlier cases, we did not put the recipient tube as yet, which we will do after the bottle is half full. Venflon goes in nicely after tourniquet, and there was a problem in the vein, so we had to switch off and then redo it again. Our efforts must be to ensure that with one prick we are able to get the vein. The heparin started, the pump flow is slow and we can see the blood rising up. It goes through the perfusion pump and then rises up to the bottle and slowly goes up. The first set of material that goes in is the heparinized part of the saline, and then the blood is mixed. Once the tube is dipping into the blood, the pump is started and the subject is made to wear an ultraviolet glasses. The UV lights are switched on blood is getting ozonated and irradiated. A recipient vein is now short. We can use a much thinner cannula for the recipient vein. We prime and flush the recipient vein, and here we have inserted the recipient set much later. The waste flow has already started bubbling out of the tube. We now prime the blood set. Excess blood is removed, air is removed, recipient side is connected. You can see the bright red color of the recipient blood compared to the venous blood of the donor color, the color of the donor blood. The procedure with the pump running at 40 ml, 50 ml per minute, ozone running at about 80 to 100 micrograms per ml, and in 35 to 40 minutes, Dr. Pankaj will get close to 600,000 micrograms of ozone in his blood. He is also a course participant and he should be on this group. I would request him to send messages about his impression, about how he felt after ozone therapy with high dose EBOO. Most of those who have undergone high dose EBOO have felt extremely satisfied and are happy with the procedure. We can see the waste port giving enough waste, and now we are finishing the procedure. The tourniquet is taken off, the machine speed is increased dramatically, the blood will flow back into the EBOO container, flask. Once that is done, heparin is closed, the heparin saline bottle is removed, the connection is extracted, the tubings are thrown away, the waste is still flowing out. You can see how bright red the blood is flowing. As a young person, we have increased the speed of blood, and once the canister is emptied, we can see how rapidly the blood is flowing into him. We have to just close it at the right time, and then both the venflons have to be removed. A proper padding or wadding has to be done, and the tubings are disconnected. The bottle can be inspected for the ozone bubbles. If you want to learn about EBOO system, the pure non-filter EBOO system, please message me in WhatsApp. Do not call, messages only. If you are already doing the course, this message is not meant for you. Thank you very much. Have a nice day. Thank you.